Okay. Dear friends, thank you very much, Yanni Iakovou, for inviting me in the wonderful meeting. My presentation is about the tips and tricks for the tricuspid valve imaging. And I will give you 5 plus 5 best tips and tricks for interprocedural imaging in TTER. And first of all, transgastric imaging is the key to the successful periprocedural guiding for edge-to-air repair for the tricuspid valve. It's important to understand the anatomy, and when we aim, okay, here, okay. If we want to put the device between the anterior and the septal leaflet, then our primary plane is at 60 degrees and the secondary plane is 60 plus 90. If we aim for septal and posterior leaflet, then primary plane is 80 to 90 and secondary plane is plus 90 degrees. And again, here is a transgastric view, and here is the RV inflow, outflow. You see 65 and 155 for the anteroseptal leaflets. But if we go for the posterior and septal, then, sorry, I have to go back. Then our primary plane is at 90 and the secondary on 180. Another suggestion is to use a single view for difficult grasping. If we have bad imaging or if we can't align our echo to the device, then we can choose a nice view to have both leaflets in and to have a symmetrical device, and then work on that view and perform also the grasping on that view. But transgastric view is very important for understanding the anatomy and measuring the gap between the leaflets. It's very important to check for perpendicularity, to check for leaflet insertion. Again, it's very important to assess the tissue that we have grasped from both leaflets. And again, another patient here. And sometimes we can see that bow tie or papillon sign in the transgastric view. It's a proof that we have grasped enough tissue of both leaflets, and that's a safe grasp. We know that the tricuspid valve has a very dense subvalvular apparatus, and it's important to avoid the chords. It's a good practice to go to the chordal-free zone when possible, so that we can be sure that we don't disrupt the function of the valve, or we don't induce a further regurgitation with our device. That's an example here. You see the chords, and we have to avoid the chords and go direct between the anterior and septal leaflet where there are no chords at all. And we have a very nice result. And of course, be gentle and careful. Is a tricuspid valve a very gentle structure, a very delicate structure, more delicate than the mitral valve, and we have to be very careful. In summary, the first 5 tricks and tips are to understand the orientation angles, to use a single view, if necessary for grasping, to check the leaflet insertion in the transgastric view, to avoid the chordal insertion zones, and to be gentle and careful. But another good idea would be to use the mid-esophageal M-TEER. As you can see, if we have a nice mid-esophageal view, then we can take a 4D data set and perform a flexi, a slice in the GE, and we can assess for perpendicularity and also perform the grasping. You can see here both leaflets and the device, and they put also a second device using exclusively the mid-esophageal view without bending to the transgastric one. But we can also, if we have a nice transgastric view, use the transgastric M-TEER, even for grasping, and go only transgastric. As you can see here, both leaflets and the device is open, and here we can go for the grasping. We check for perpendicularity, and we perform the grasping. As you can see, we record the grasping here, and we avoid, once again, the bending between the transgastric and the mid-esophageal view. That's time-saving, and of course, we can avoid some problems with esophagus, and we have a very nice result. Okay. If necessary, we can also perform an angle reset. Normally, we take the primary plane and then we put plus 90 degrees on the secondary plane, the biplane or multi-D, but sometimes it can be less or can be more, and it depends on, I think, the location of the device. It's important to show both leaflets and, of course, to have symmetrical, wide open our device. Another good practice is to record the grasping, to record 10 or more cardiac cycles, and then to review the grasping to be sure that we have enough tissue of both leaflets so that we can avoid or reduce the possibility for single leaflet detachment. And finally, the last tip is to use, if necessary, peri-procedural the transthoracic echo, because it can add to the information of the grasping or help us assess the final result. In summary, we can use the mid-esophageal M-TEER, we can use the transgastric M-TEER, we can perform an angle reset if necessary, we can record the grasping, and additionally, we can use also peri-procedural the transthoracic echo. Thank you very much.
All right, great. And let us complement this one by going online to Dr. Chrissoheris,